We have a very special interview today with Dr. Eric Robbins, a clinical urologist. He's been working in Southern California with chronic pelvic pain and unexplained and difficult cases have all been regionally referred to him for years. And we're so lucky to have you here, Dr. Robbins, because it's really rare to find a urologist that understands the mind-body connection. And so thank you for doing this.
I'm so happy to be here, and I was happy you sought me out. And I wish there were more folks like me that are kind of incorporating the mind-body holistic stuff in their practice, and particularly in their pain practice. So, and I know, just as a shameless plug for your book, you may not even mention it, but I love your book, and it's something I wish I had had to give to patients 30 years ago. And it totally aligns with the stuff I do. So yeah, we're definitely melding minds here. And so yeah, I'm looking forward to this interview.
Absolutely. And that's what I was going to jump into, is kind of how we met. And what happened is I did a TRE session for the first time, and I was like, whoa, this is crazy. A practitioner guided me and my body was tremoring and shaking. And I had this deep relaxation, like a very deep meditative state. And we talked a bit after about the work that I do. And she's like, oh, you got to reach out to Dr. Robbins. And I did. And yeah, since then we've connected. And exactly like you said, I've been studying, and I went through a lot of this as a patient myself, and had to learn things that really weren't available. The resources weren't there, like 12 years ago, very much on the internet. And, but then also to see how you've been doing it with the urological perspective and the anatomy and the physiology and the medical concept, like how can you bring the two worlds together successfully, I think is really exciting. And, but yeah, I'm really glad we met too. And I appreciate your help with the book as well and everything else. So I wanted to ask though, like your professional setting, just so people can get an understanding of what kind of work you've been doing. Can you describe it a little bit?
Yeah, sure. So I graduated urology residency at USC in 1995 and immediately joined this large medical group in Southern California. And we take care of close to 5 million members. So when I say like I'm a referral specialist for chronic pain, that's a lot of patients from, 12 or 13 different medical centers. And yeah, it was interesting. At USC was a major cancer center. And so I was really good at major cancer surgeries. And I got into private practice, and like someone would say, like, I'm having pain and I got to pee a lot. I'm like, do you have a muscle invasive bladder cancer that we can take out? She's like, no, just got to pee a lot. I'm like, do you have like a, renal cell cancer going up your vena cava in your heart? No, I got pain down there. So I was really good at the big oncologic stuff and a little bit less so with the bread and butter stuff. And but you get practice for a while, I realized that, medications work well, but sometimes they don't work and there's a lot of side effects. I grew up with a mother and sister who were both very, very sick. I can remember coming home from school every day and my mom was sick in bed my entire childhood. And my sister similarly had some very similar symptoms. And I ended up having like a 35-year bout with pretty severe chronic fatigue syndrome and brain fog. And so I was getting into practice, seeing some of these patients that couldn't be helped with standard therapies. I was trying to figure out what was going on with my mom and my sister because they had couldn't be diagnosed, and it was by standard medicine. And they went to some psychologist who said, well, they're not crazy. So, where do folks like that? And I was trying to understand my own energy levels. And so that kind of led me into a study of a whole bunch of different alternative holistic healing paths, trying to help myself, help my family, and help my patients.
Yeah. So yeah, just to be clear, you have been a practicing urologist with a lot of patients coming in, working with you in person most of the time, I'm going to guess.
Yeah.
What is it like whenever they come? Do you have a particular set of diagnostics, or just in general, what would it look like for a client that comes to visit you?
Yeah. So as I'm sure you know, the American Urology Association has guidelines for how we manage different diseases, including chronic pelvic pain. And so we always want to go through and check off all those boxes, obviously. And then the challenge is that we've got a lot of really good, smart urologists in our system. And so oftentimes the patients come to me and they've already had all that stuff done. And so at that point, once we make sure there's nothing pathologic, anatomic going on, that's when I kind of get to play with some of these mind-body things. I mean, I would say the process is when people come to see me, check off the boxes for that. And then, I'll kind of launch a little bit more into like the global understanding that I have. But I'd say after seeing chronic pain for a long time, it usually boils down to a couple of different things. There's a big component of nerve hypersensitivity, and those hypersensitized nerves will send a false or magnified message to the brain. and or there's a lot of pelvic floor muscular tension and spasticity, and that also contributes to the pain. That's kind of a boiled down essence of a lot of what I find. And then at a higher level of truth, you'd say like, yeah, but why are those nerves hypersensitized to begin with? And why are the muscles tense and tight? And frequently that has to do with kind of how people process their emotions, how they store past traumas in the body, how the effects of early life stressors and traumas have programmed the physiology to run. So almost everybody with chronic illness of really any sort or chronic pain, their bodies and their physiology are running in a chronic fight, flight, freeze, stress state. And even though we say the body tends to heal itself, it doesn't heal very well in a stress physiology. So at the end of the day, and what I've been doing all these years and synthesizing and integrating is finding ways to shift folks out of a chronic stress physiology into more of a parasympathetic, ventral vagal, rest, digest, restore state.
You pretty much just described how it works. You described how it works.
The entire interview is over now.
120 seconds. Everyone, please reread that in the transcript like 5 times because it was extremely loaded. It was extremely loaded with goodness, though. And I think that there is a lot of confusion. First of all, yes, visit your urologist, visit practitioners so that you can check off the box because there could be a rare pathological aspect, an organic disease process. And by all means, get some help with that from the biomedical system. And the case that that's not there, you're scratching your head, then why the hell do I have severe pain? Why is there so much gripping tension? Why do I have so much trouble peeing every day? There's clearly something at play. And then people will tell me, but at times at least, they'll say, but I'm not really that stressed. I mean, like I just go to university and I do this, or I have a job and I have a loving wife. And they'll say like, I don't think I have excessive stress necessarily. And you pointed out this stress physiology. And I find that it's a blind spot. It's very much the way you are patterned, and that there is this sort of allostatic load that gets built up over time through certain environmental stimuli. And you don't notice it because it's who you've been since you were a kid, essentially.
Mm-hmm. Yeah. I mean, I think a lot of times chronic pelvic pain, it's kind of like the engine light on your car. I mean, a lot of times that engine light goes on and you're not really aware of what's going on until you open the hood and look inside. And so chronic pelvic pain is the same way. It's a lot of times a great indicator of stress, maybe a built up inflammation of the body. And I would almost say the presence of the symptoms presuppose that there are, underlying stressors or stress physiology or something like that going on. To me, you can almost presuppose that that's the case, whether they're consciously aware of it or not. And what I like about your book, you're literally bringing people's conscious awareness to that. That's exactly what your book is all about. And in some ways that I know about, and even some ways that I didn't. So, yeah.
So you mentioned two really big things. You were like, from your perspective, nerve sensitivity, and then also muscle tension. And I think you had another word related to that. Let's look at the nerve sensitivity aspect of it. Could you just break it down a little bit more? What could be taking place there mechanically with the sensitivity of nerves and why that would produce symptoms?
Yeah. So, I mean, a few examples of nerve hypersensitivity, like we see in interstitial cystitis, for example, most of the time, if you look at these folks' bladders, the mucosa and everything looks normal. And it's usually an inflammation of the inner wall or the interstitium of the bladder. And some of the most pronounced symptoms are those of nerve hypersensitivity. So someone feels like they got to urinate frequently and urgently. I've got some IC patients that'll urinate and they're emptying fine and the bladder looks normal and, they don't have any infection. And 5 or 10 minutes later, they'll feel like they have to go back again. So that's an example of some nerve hypersensitivity. I had my father-in-law, this is a non-pelvic example. My father-in-law lived with us for a while. And every morning he'd wake up and he'd say, my feet feel like they're freezing. So that's the message his brain was getting. But if you went in there and examined him, his feet were nice and warm, good pulses, good blood supply. So the problem was not, quote, all in his head. It was real, but objectively, there was really not much going on. So, but those nerves were lying to him. Or, I had a patient who had seen 10 other physicians and he came in and said, Robbins, it feels like there's a red hot knife jabbed in my pelvis and in my bladder. So naturally, we examined the guy, reviewed his imaging. And as you can imagine, there's not really a red hot knife there, but that's how it felt to him. That's the message his brain was getting. So that's kind of ways that nerve hypersensitivity presents. I had a lady last week who said it felt like a cat had scratched the inside of her vagina. again, there was nothing, objective, no cuts or lacerations. So all those are kind of examples. Again, kind of the higher level thing. Once people wrap their heads around that he's not saying the problem's in my head and what I'm feeling is real, but there's nothing physical, anatomic, pathologic to account for it. It must be nerve hypersensitivity. Then the higher level question is, well, why would you have that? And so very commonly, when people are stuck in a chronic stress state, the stress hormones do a bunch of things. They sensitize nerve fibers and pain fibers. So that right there is the deal. And by the way, when people are having pain, and then not only are they having the raw sensations of the pain, but when they think about it, it's making them more stressed or anxious. That essentially is putting them more in a fight or flight state, which then actually makes the nerves hurt more and things do hurt more. So that's kind of a spiral. So I know you do a lot of work and kind of cognitively working with how people process their sensations. I'm sure we'll probably come to that later. Elevated levels of stress hormones also increase the amounts of inflammation of the body. And I mean, everybody knows inflammation makes everything worse. When we're stressed, we're kind of in a protective state, and the muscles and fascia throughout the body, especially the pelvic floor, lock up and gets tense and tight.
Yeah, so that tension, that tightness, it's a protective mechanism almost gone wrong because it's happening unconsciously.
Yeah.
But the nervous system is very primal, it's very ancient. It's just responding to the way it has been molded to this
Yeah.
body.
Well, Wilhelm Reich talked about Reichian armoring, and basically how he described it is that if someone's experiencing something in life, particularly when we're young, and if at the time it feels stressful, terrifying, overwhelming, and we can't fight or flee. If somebody's having a little kid, they're not going to fight. They're probably not going to be able to go anywhere. And he says, we'll freeze. And he says certain muscle groups in the body will lock up and get tense and tight to literally hold those emotions and memories in the body and keep them from coming up to conscious awareness. So there's always kind of a process where as folks, as we get those, as those muscles are able to relax more through therapy or TRE or other modalities, sometimes one does have to be able to process what comes up, kind of the emotional, mental content of that.
Yeah, it's extremely important to point out. One thing that, there's just a lot of confusion around the muscle tension side.
Mm-hmm.
And people typically are looking at things like my hip flexors are weak or my glutes are weak or I have a pelvic tilt. There's some sort of misalignment that has taken place, probably because I sit a lot, or maybe the way I've been walking or the way I've been breathing. And I definitely do think it plays into the way that the body is molded. But
Yeah.
what are your thoughts on these biomechanical factors and how they affect or create these chronic symptoms?
I think when you treat them, so I think pelvic floor physical therapy is great, and it's actually revolutionized a lot for us. So I think it's fantastic. And there's people that work diligently with it to get a tremendous amount of improvement. But once again, kind of the higher level thought is the muscles are tight, and that's when I'm symptomatic. But why are those muscles tight to begin with? And again, it's going back to what we just said. There's frequently a reason for it. Like it doesn't just happen in a vacuum, and it's frequently how our emotional junk is held in those muscles. And so ultimately, if you want the muscle to stop just contracting, I mean, you go to a massage therapist, you go to a physical therapist, they work that muscle and it will relax. Oftentimes that's great. But then, as most of us know, the muscle snaps back and tries to contract again. And so I think it's not until you deal with the underlying emotional content held in the muscle and are able to process it that then the muscle is able to relax and not come back and tense again. And I've got a couple of great examples of that if you want to hear them, maybe now or maybe a little bit later in the interview.
Yeah, let's actually hear at least one of them now. That'd be great.
Okay. Well, I'll tell you, they both kind of fall in line together. So I saw two women in their early 20s, and they both had a lot of pelvic floor spasm. One woman had vaginismus, which, as you know, is where those pelvic floor vaginal muscles are so spastic she couldn't have intercourse. The other woman, her pelvic floor was so tight that every time she wanted to urinate, she'd be on the toilet for 5 to 20 minutes waiting for that muscle to release. And both women, because I understand these processes we're talking about, I asked them multiple times, do you have any trauma, any history of trauma? And they're all like, no, nothing I remember, nothing at all. Anyway, so we did TRE with them. And what I know about TRE is that when we activate this tremoring mechanism in the body, it normally starts in the inner groin adductors and the pelvic floor. I know that very quickly it's going to relax some of the tension and armoring in the muscles. And then what's there will come up to conscious awareness to be dealt with. That's a process I see on a daily basis. So both women, we did TRE. After about a minute of tremoring, both women started tearing up and crying. So the gal with the vaginismus suddenly remembered that there was a date rape in college. And there was a tremendous amount of emotion that as we released those pelvic floor muscles that started coming up to conscious awareness, to deal with. And as we helped her move through some of those, I think in her case, we did EFT, the emotional freedom technique. It's a form of emotional acupressure. Once we cleared the emotional charge of that event, her muscles were able to relax and stay relaxed. And she was able to have normal intercourse after that. The second woman, her mom was in the room with us, and her mom told me she'd been in therapy for 3 years and nothing ever came up. But in this woman's case, a male relative had inappropriately touched her when she was a kid. And again, once she dealt with that with a therapist, the muscles were able to relax. She was able to urinate much, much better, much easier.
That's incredible. I mean, these are real stories.
Yeah,
And
exactly.
they're quick. Saying that they're quick shifts may be wrong, but in a sense, these were pretty quick turnarounds, right? It wasn't that they had to do a certain exercise for like a year straight to release the tension.
Right, right. I would say probably both of these women probably didn't have a lot of early developmental trauma where a lot more of their body was locked up and they're really just so physiologically frozen. That those patients can take more work. I kind of fell into that that category of a lot of developmental trauma and my whole body being locked up. And so when you have something like that, it's not these 5 or 10 minute miracles like I'm describing, but these cases are, I mean, they're just it's not like an accident. It's like the process that I see day in and day out. And so, yeah, it shows people what's possible. And yeah.
Yeah. And this is what really brought me to going to the root causes or writing the book, The Root Truth, because even in my own case, like when I had severe issues, I did pelvic floor physical therapy for a year, got 80% better. I mean, that was a big change.
Yeah.
After a few months, things were happening, symptoms came back like as they were before, almost as if I wiped
Yeah.
a year of work. And then I've seen with other people that they'll be like perfectly doing the exact exercises just right, going to PT every week, following the system, the exact diet. And it's like perfectly like forcing and holding it all together. And they're holding it all together and they're good. And then maybe they're good for a while. But if you don't really address some of these underlying factors, they may have another kind of mind body syndrome. They may have IBS or headaches or back pain. Like, oh, now I need to go to that doctor. Now I need to go to do that. Now I need to fix that. And they're seeing them as completely separate, but they're not separate. And it's not that we go to the root cause and we fix it and now we'll never have symptoms our entire life. But whenever you go to a deeper layer of awareness of what's really being held within the self, you aren't going to immediately jump at an externality of like, oh, I need that medication or I need to like go get that person to fix me because, oh, let me sit with what's here first.
Yeah.
And that's why the approach makes the most sense to me as a holistic, self-directed, even
Yeah.
self-awareness approach.
Yeah. Yeah, exactly. The same physiology that leads to chronic pelvic pain applies, I think, to everything from migraines to irritable bowel syndrome to, to the dysautonomias to so many of these kind of seemingly diseases that are relatively uncurable in standard allopathic medicine.
Exactly. So you mentioned already kind of some of the underlying principles of why you're perceiving these symptoms are being created. I was wondering, what would your step-by-step process look like to help someone to heal, and generally speaking, for some of these chronic pelvic urinary sexual conditions?
Yeah. So I still refer a lot of these patients for pelvic floor physical therapy, and I still use a ton of nortriptyline or gabapentin, which are medications that calm down these hypersensitized nerves. And I do think that a lot of times, nerves know how to reset themselves. So in a lot of cases, just the still kind of standard stuff helps. But in the folks where it's not helping, it's kind of interesting because people come to see me as a standard urologist, and I very, very quickly have to get them to the point where they understand that there's nothing serious causing the symptoms. And just kind of like the 2-minute spiel that I gave you in the beginning, I'm summarizing a tremendous amount of stuff to make the leap from, yes, your symptoms are real, but there's nothing physiologic that we're going to do about them. And we need to look at shifting your body out of this chronic fight, flight, freeze, stress state so that everything can heal itself better. Now, for some folks, I'll tell you, and this is classic for like a lot of chronic testicular pain, because most guys with chronic testicle pain, they come in, they're worried something serious is going on, a tumor, an infection, a whatever. And once we can rule that out, for a lot of guys, the raw sensations of what's there is not that bad. And once I can reassure them nothing's that bad, they start to think about it differently. And there's always, for people with chronic pain, there's always the ones that get their cure, there's always a component of changing how they think about it. Because so many people, they have symptoms, they had layers of thinking about it, of emotions about it. They remember the last time they were in the emergency room, and that keeps them stuck in a fight, flight, flight state. And the symptoms just keep getting worse and worse. Or I know from your book, we both see these guys that come in and they have like a hard flaccid syndrome, or they notice just little tiny skin pigmentations changes on the glands, and they're just focused on that all day long and worrying about it. And I see them multiple times. Do you see this? Do you see that little tiny splotch? And there's minimal to nothing there. And again, a guy like that will get their cure when they say, you know what, maybe there's a little pigmentation change. The doctor said it's nothing serious. And if I can just stop worrying about it or start thinking about it differently, that by itself calms the nervous system a lot.
Yeah, so the education is really helpful,
Yeah.
knowing because this isn't common knowledge for some reason. We're not taught this whenever we're going through school, or even many medical schools aren't teaching things to this degree.
Yeah.
So beyond the education, you're often prescribing certain medications, in certain cases at least, pelvic floor physical therapy. Do you then have follow-ups beyond that, or like how else do you work with someone?
Yeah. So assuming that patients are kind of buying into what I'm telling them, I'll usually teach them the TREs, which is the tension and trauma release exercises.
Could
I've
you
taught
describe
about,
that a little bit, just because a lot of people may not know what that is?
sure. I'll give you again just a couple minutes spiel that I give to the patients. And so I'll say, I'm sure you've seen on TV or something before, YouTube, like the lion chasing the gazelle. Most people have seen that. The gazelle's literally running for its life, and its body's in a high level of fight or flight stress. Now, what's interesting, if the gazelle escapes and gets away, and it won't do this till it feels safe, its body will shake and shiver and tremor. And every animal and every mammal and all of us have this built-in shaking, shimmering, tremoring mechanism that does a couple things. Number one, it turns off that fight, flight, freeze stress switch. Now, by the way, just that by itself is amazing, because most of us, most humans, if you have something horrific or terrifying like that, may get a PTSD picture, but our physiology frequently doesn't just normalize. So these gazelles or these animals will shake and tremor, and they'll normalize. They'll go back and hang with the herd and take care of their young and graze. And yeah, they're kind of not stuck in a PTSD state. And then the other thing I always say, if you imagine 1 minute, the gazelle's eating the grass, grazing, and then that cheetah creeps up, and in half a second, the gazelle's running 50 miles per hour, jumping, and there's a lot of charge and survival energy running through its body, through the musculature. And the analogy I give is like if you have a can of Coke or Diet Coke and you shake it up, now there's a lot of pressure in the can. Obviously, we don't want to just rip the lid off and spray Diet Coke all over my room, but what we do is we just start to crack the lid. You slowly, safely depressurize the can. So when there's a lot of survival energy locked into the body and to the musculature, that's one of the things that kind of keeps us stuck in this fight, flight, freeze stress state. And it kind of contributes to these muscular tension and bracing patterns, again, that are on autopilot. So you get a massage, but the muscles tense and brace back up again. So this guy named David Berselli, who I know you had a great interview with not too long ago, developed a technique called TRE, stands for tension and trauma release exercises. So you do some simple exercises, and it activates this involuntary shaking, shivering, tremoring mechanism in the body. It normally starts in the inner groin adductors, and over time it'll move through the pelvic floor and the quads and the hams and the psoas muscles. And by the way, the psoas muscles are the biggest fight or flight muscle in the body. They've got a huge amount of sympathetic innervation. And I always tell folks, if and when the tremors get up into your psoases, it is life-changing because it's so effective at just relaxing the body and the physiology. So the TREs do kind of exactly what we see in animals. Over time, it shifts folks out of a chronic fight, flight, freeze, stress physiology that's running on autopilot. And then it also, over time, the tremors seem to unwind these chronic myofascial tension and bracing patterns in the body. It starts to relieve the survival energy that's built up inside. By the way, Peter Levine, who developed somatic experiencing, talks a lot about this trapped survival energy in the body and how it keeps us stuck, doing and feeling horribly. So to be able to release that is really a gift. So those are the true reasons why I like to teach it to these patients because it's addressing at a much higher level what's actually going on with them.
That's incredible. When with TRE, do you recommend, hey, you should do this 3 times a week for the next few weeks? Or like what sort of guidelines do you typically give people?
Sure. So, it's interesting because most folks, they do become TRE practitioners, and on the classes we'll have people tremor for 10, 15, 20 minutes. So I would say that's standard for most good practitioners in practice. I think one of my biggest contributions to TRE is realizing that there is a cohort of patients that if someone has a lot of trauma, they have a lot of physical diseases that imply that the trauma is there, whether they're aware of it or not. You want to go very, very slowly. Just like that example I gave a few minutes ago of those two women, in both of them, it was a minute or less of tremoring was able to release what was there up to conscious awareness. So for the cohort of patients that I see in my practice with a lot of chronic illness, their bodies are very locked up. There's probably been a lot of early life stressors or traumas. You want to go very, very slow. And the challenge is not that TRE does not work. The challenge is that it can sometimes be very effective. So in my office, I'll sometimes start people tremoring for 30 seconds or a minute. And I'm watching to make sure that they're not, freezing, flooding. They're not flooding with emotion or memories. They're not disassociating. And some people, for example, these tremors, when we do them, by the way, people would probably have to watch a video of them, but those tremors are happening automatically without our conscious control. And so for some people, boy, that feels really out of control, kind of makes them anxious. And so I think my contribution, I had a video out called How I Do TRE with Sensitive and Fragile Clients or Patients. That's gotten as many views as anybody. And so many people have written me back channel to thank me because, just doing a little bit less TRE, going slowly, safely, they're able to release a lot of tension. They're able to calm down that physiology, but we're not doing too much too fast where they're kind of flooding with emotional stuff that they're not quite ready to process.
That's incredible. Outside of the TRE and perhaps pelvic floor physical therapy, other things that you talk about, are you recommending any kinds of exercise changes, activity changes, dietary changes? What else would you recommend?
Yeah. So I mean, some of like the professional guidelines for bladder stuff, interstitial cystitis and chronic prostatitis, or things like watch dietary irritants, things like caffeine, hot spicy foods, alcohol. So we do ask folks to kind of, watch those to some extent. We never want to send people out where they feel like they got to live like Mahatma Gandhi. We're like, there's no joy in life. We'd obviously I like to eat. So, maybe watch those irritants in moderation. It's interesting because a lot of folks, they have their pain and they stop exercising and they're worried that they're gonna hurt themselves or it's gonna make it worse. And that is almost never the case with the types of pain I see. Maybe someone's got a slip disc in their back, their doctor may think otherwise, but for most chronic pain, I want people to actually live their lives, and exercise, as you know, is a great stress reliever. And I don't want to put limitations on the exercise. Yeah, I mean, some other things we do, if I've got the time and someone has some known traumas that when they think about them still have a big emotional charge on them, some of my favorite techniques are EFT, which is the emotional freedom technique. I also like TAT, which is the tapas acupressure technique. And both of those are very good, effective techniques. They're frequently fast enough to use in the office at clearing the emotional charge off of past traumas. And a lot of times that also helps the body kind of calm down and just settle into more of a ventral vagal parasympathetic healing state.
That's beautiful. We really don't have to complicate it too much more. I mean, giving people the tools they need in the moment, but
Mhm.
if they understand the underlying premise as to why their body is creating the
Yeah.
symptoms, we're just helping the nervous system de-stress, regulate. I love the soda can opening metaphor sound, like just let
Right,
a
right.
little more out, let a little bit more out. And
Yeah.
that's how it works too, because people want to heal like really fast because they're like, oh my God, it's been 3, 5 years. I haven't really lived life. And it's not that it has to take a really long time, but you're letting a little bit more out. You're getting more relaxed. And it's a new way of being too, though, because
Yeah.
that's what I had to learn is this, let me regulate my nervous system, let me calm down, let me slow down. It's not now that I feel really good, rev it back up to 120 miles per hour
Yeah.
because that's not going to work. So a lot of times people will say, I want to go back to the way I was before. And I'm like, you can't go back to the way you were before because that's what made you sick.
Yeah, exactly. And by the way, it's usually not these like bad Sutherland guys that get chronic pain. It's like guys like us, like you're a nice person, you're loving, you're spiritual. maybe, at least in my case, had a little bit of a perfectionistic thing, but you're good people and your personality is built around kind of being a good guy and not being like overly emotional. And I for decades didn't want to get angry. And that was just like, oh my God, how could why would I do that? That's horrible, and I would have anxiety, but try not to show it. So yeah, you're right. You can't quite be the same person you are at the beginning as you are at the end when you manage to cure the pain. But yeah, I just want to clarify for the audience, people can get cures from their pain, not just managing it, not just treating it, not just on pills for a lifetime. You can actually cure it. But again, you're not going to be quite the same person as you were when you walked in the door. You're probably going to be a better person because you're more open to your emotions and you're not holding as much repressed stuff. And you're probably much more authentic with your emotions. And I'm actually happy to get a little pissed off every now and then. I mean, it's not often, but it's who I am. And I think I'm more comfortable letting people in and seeing me for all the facets and even the kind of unspiritual ones. And yeah.
That's amazing. I love that. That leads me to wanting to ask you about your back pain story. You did
Mhm.
share this in the book, The Root Truth, but for someone who hasn't read that, I think it's really powerful if you could share what you went.
Sure. Sure. So I had some back aches, on and off for a while. We do long surgeries. You're standing over the table and bent over and twisted and working in someone's pelvis. So, I mean, most guys have a little bit of background tension, but one day we were driving somewhere and I came across a bad accident and I spent thousands of hours in the field with the paramedics. That's something I do on the side. So I'm pretty comfortable doing pre-hospital care stuff. Stopped this accident. This car was upside down. This woman's laying in such a way her airway was being cut off. So she wasn't really moving any air. And so I had to crawl in this little opening in the window and I'm on my knees and I'm extending my arms forward to support her cervical spine and open her airway. And someone gave the paramedics the wrong address. And it seems like I was in that extremely awkward position for probably 10 or 15 minutes. And it put a huge amount of stress on my lower back. And so once the help arrived, I got up and my back just immediately went into spasm. And, I get our master bedroom, like the bathroom's like 15 feet away from the bed. And it was spasming so bad, I had to crawl on my hands and knees. It took about 20 minutes or something to get that 20 feet. It was crazy. But I was missing a lot of work initially. So um, I, I really didn't want to get cut on. I mean, I wasn't even interested in pursuing really an MRI. And I didn't have any of the serious symptoms that might send you like straight to a spine surgeon, like loss of bowel or bladder control or foot drop. So I came across this guy named Dr. John Sarno. You know him well, professor of physical medicine at New York University. And he had the highest success rate in the world with seeing really refractory cases of chronic pain. And most of his patients had already done years of physical therapy and had prior surgeries, and their x-rays looked horrendous. And he still had this amazing cure rate. Sarno's philosophy, which I very much resonated with at the time, said something like this. He said, first of all, most people with back pain, they come in and usually the doctor does imaging and he'll say, for example, it's that slip disc with a spinal stenosis or spinal arthritis that's causing your pain. And then standard medicine aims to fix those things. That he said the challenge is that a large percentage of normal people with no pain, if you do an MRI scan, have those same symptoms. So he said it's probably not those things that's causing the pain, but then he asked himself, well, if it's not the slip disc, degenerative joint disease, what is causing the pain? And he found out that frequently it's muscle tension and spasm. And he says, these muscles will lock down and be tense and tight. And then, of course, there's less blood flow going through those tight muscles and less oxygen. And he says that can cause a very real physical pain. So Sarno then asked himself a really interesting question. He said, well, yeah, but that makes sense. But why would someone have tight spastic muscles to begin with? And I love his explanation. He said that for many of us growing up at some level, it could be a good family, it could be a bad family. At some level, we learn that it's not okay to feel or express certain emotions, particularly anger or anxiety. And he says, so when those emotions start to come up from the body, a part of your brain will say, it's not okay to feel that. That's not safe. That's not what kept you, alive when you're young. And he says the brain will cause these muscles to clamp down to cause the pain, to take your mind off what you're angry or anxious about. And I got to tell you, that hit me like a ton of bricks in a good way. Like I realized, I think that's what's going on. I got to say, I was so tremendously repressed that when I first started asking myself, when I have pain, I wonder what I'm angry or anxious about. The answer was not right there. but I was very, very persistent. In fact, I tell people I literally would have been willing to die to prove that this philosophy was correct. I closed every other door for myself. I don't advise other people to do this. Every other door, and I said, I'm gonna find what's going on under the surface. And it took some work and it took some persistence. And I started noticing that a millisecond before my back would go out, I'd have some sort of anxious, disturbing thought about my wife and kid, something like that. And then the back would go out. And then I started realizing, hey, I've got you. Like there is something. In my case, I had to do some therapy to get in touch with some deeper emotions. And but the interesting thing about Sarno, because he says, for example, most people are upset with their boss. Most people think they have two choices. You either punch the guy out or you take the emotions and shove them down deep inside and, repress or suppress them. And he said there's this third option where what if you just notice the emotions and open up to the raw sensations of them and let them be there, and you're not necessarily expressing them and you're not necessarily suppressing them. So it's interesting because some people, when they get in touch with these uncomfortable emotions, think they have to get rid of them. And that's not part of the Sarno equation. It's just learning to be with them and accept them. It's easier to do that if you accept them as a raw sensation and don't add a bunch of thoughts about them and stories. And anyway, so I did the Sarno stuff. All my pain went away. That's been 29 years ago now. I think in the past 29 years, I've missed work one day with back pain. And even, I'll go to lift something heavy these days, and Linda will say, Eric, don't lift that. You got a bad back. And I can honestly look at her and say, no, I don't,
That's
So
amazing. Yeah, it was a cure, like you said. It wasn't,
yeah.
you kind of managed it, and then it just kept
Mhm.
coming back and coming back.
Yeah.
Um, I
It
love,
did take some work and exploration though, as you
yeah, yeah,
know.
a lot of commitment.
Yeah,
One thing that was important is that you said you shut down the other doors. And it's not that you have to be an extremist. It's just that I think I talk about this in the book. If you're riding two horses, you're going to get split down the middle. So if you're like, I don't know, but like I need to go to my third urologist, like let me do a second MRI. There's like maybe there's something really happening in the body structurally, and that's what's causing all of this. You're
right.
like, maybe it could be emotions, but I just don't know what they are. And that's how it is, right? Because if you knew what it was and you knew how to process it, you wouldn't have the symptoms.
Yeah,
So
I mean, that's exactly what repression is, at least according to like Wilhelm Reich and the Reichian armoring. These muscles are doing such a good job clamping down to hold the emotions in there, so they're not coming up to conscious awareness. So you're exactly right. You kind of have to take a jump of faith at some point. I know there's got to be something going on there that's keeping this pattern persisting, and you probably aren't consciously aware of it, and it takes some exploration and some exploring, and within reason, once you've gotten totally cleared and seen several opinions, whatever, had the imaging, to really focus on that. And it is a process for sure. But again, those people are the ones that get healed, which I love.
that's amazing. And I'm glad that you're healed too and that you can pick things up.
Yeah.
Pain and pain. So I'd love to move on to some Q&As, and
Mhm.
these are directly from people in the community. So thank you to everyone who submitted these. And again, we have a disclaimer in the description and everything, but Dr. Robbins is not diagnosing or treating. He's giving general information based upon the questions. So the first one here is hard flaccid sufferers are known to have no damage to their private parts from the point of urology. Is hard flaccid, after all, a mind-body syndrome? Just a little bit of information on this.
Yeah. I think hard flaccid to me is basically, the penis is like the engine line of the car again, and it's reflecting the body's probably going back and forth between a sympathetic state. Obviously, when we're in a sympathetic nervous system state, a fight or flight state, the blood is not going to the penis. I mean, that is right. That's not arousing. I would say if you're in the woods and a bear's chasing you to maul you and kill you, and you're running for your life, you probably don't have an erection. So being in a sympathetic state obviously causes the penis to shrink up, the smooth muscle to shrink up. When we're in a parasympathetic state, maybe it's a little kind of firmer than maybe average. But yeah, hard flaccid to me is just the penis reflecting the folks are in a state that is varying between a dorsal vagal parasympathetic state. And by the way, dorsal vagal is not the good rest and digest parasympathetic state. It's kind of the bad stepchild of it. I think you discussed the Porges polyvagal theory in your book, and I discussed it in everything I teach. But it's just the penis reflecting that the body's cycling between a sympathetic nervous system state and a dorsal vagal state. And that's what you're seeing down there. And again, you can get out of that physiology. It's a process. a number of the tools that I teach and that you teach will do that. So yeah.
Thank you for that. The next question is, I have been suffering from chronic prostatitis, CPPS, for more than 2 years. Has this condition ever been completely cured?
Yeah, for sure. One of the things, chronic pelvic pain, there's always a chronic, yeah, the CPP, yeah, there's almost always a component of really tight lockdown of pelvic floor muscles. So, normally during our day, the pelvic floor, the levators, the external sphincter, that's all kind of refers to the same thing, is closed to some extent. So we're not leaking urine as we're walking around. And when someone goes to urinate, and the first thing that happens is that pelvic floor muscle is supposed to relax and open up, and then the bladder squeezes and the urine flows out. So a lot of times with chronic prostatitis, those folks are walking around with a lot of extra tension in that pelvic floor muscle. So they go to urinate and the muscle just kind of releases just a little bit. And then the bladder squeezing and the urine's hitting that partially tight pelvic floor muscle, and some urine can back up in the prostate and inflame it. So for a lot of times, chronic prostatitis, there's a component of a tight pelvic floor. When I do a prostate exam on these folks, I mean, every urologist in the world inserts the finger and he's feeling the prostate and they want to see if it's mushy or boggy or feels inflamed. And I'm doing that, of course, as well. But I also take an extra 2 seconds and I'm feeling, can this person relax their anal sphincter muscle? Some people are locked down like vices and they're trying to relax, and I'm coaching them to relax and they just can't. So that's good information for me to know. Or sometimes you put the finger in and you feel the muscle spasming on it. Again, it's subtle, but I'm making note of those things. And so, yeah, a lot of times chronic prostatitis is related to a tight pelvic floor. So TRE is helpful. Pelvic floor physical therapy is helpful. There's probably a component of some nerve hypersensitivity, as there is with most of these pain symptoms. Yeah.
Thank you for sharing that. They get a two for one with your anal diagnostic. With the pelvic floor PTs do the same thing, right? But you're actually checking multiple.
Yeah, they do. Right. But
Yeah.
most urologists aren't. And
Yeah.
again, I don't expect them to. Most guys are not really, don't really like treating pain. And so they're not adding a little extra thoughtfulness to the exam. But yeah, you can gain a lot if you do.
Yeah, amazing. The next one is, as soon as I wake up in the morning, I have an urgent burning need to urinate. After urinating, the burning sensation continues. Under these circumstances, I have trouble relaxing during any exercises, including breathing exercises. So, because of that, they have little or almost no effect. Any comments on this person's situation?
Yeah. I mean, again, we would rule out the normal stuff. We'd make sure this person's emptying their bladder well, that there's not a UTI. I don't know how old this person is, what prostate cancer, whatever. But assuming all the workup is negative, again, now some people, if they're not hydrating themselves well, the urine will be very concentrated. And I mean, in my case, sometimes I'll have this urine, burning with urination. My urine's concentrated. The difference is that when I have it, because I'm in the business, I don't freak out about it and start wondering, gee, is something severe? Because I'll tell you, we learn stuff very fast as humans. Sometimes like something happens once or twice, and it's already like a learned response, like, oh my God, it's going to burn, and we're kind of bracing against it. And so there's the muscles unconsciously, the pelvic floor muscles are clamping down. It's like, it's interesting as a quick aside, but if like a little kid has a urinary tract infection or something, and it burns when they pee, very quickly, this kid's pelvic floor almost has a mind of its own. And in simplistic terms, the primitive part of the brain thinking, it hurts when the urine comes out. In order to protect this kid, I've got to clamp down. And so the pelvic floor muscles will clamp down, but that makes the burning much worse, not better. And it very quickly becomes a spiral. And sometimes adults are the same way. So I'd get everything worked out in this case. That you may need some medication to treat nerve hypersensitivity for a while. You might need to work with a pelvic floor physical therapist because there's probably some pelvic floor tension and spasticity. I think, again, I would prescribe TREs for almost all these folks. And yeah, I mean, I think this falls into the realm of exactly what you discussed in your book.
Amazing. So, this one is kind of similar, but maybe you have some other thoughts. And the question
Mhm.
is, what should I do after urinating in the morning to make it better? And I think they're talking about feeling discomfort and weird sensations probably after they pee. Anything that they should do right after they urinate, or do you have any recommendations?
I think, again, I would treat that the same as, is this the same second part of the question we're
Actually,
saying?
it's a different
It's
person.
a different one. Yeah, I'd say the same. The answer would pretty much be the same. It's just you're looking at pelvic floor spasticity, depending on how severe the symptoms are, some nerve hypersensitivity, and yeah.
Yeah. I mean, because exactly what I would say is, in the moment, the question was asked to you, not to me, but relax and release, take a breath, not being so concerned about it, like you were talking about, is important. And then follow the path of everything else that we're discussing, though. It's not that there's
Yeah.
one quick tip, one quick trick for 3 minutes every time after you pee that will make you better. Because then you're just, again, kind of symptomatically addressing something anyway.
Yes. Yeah. Exactly right. I mean, people, yeah, depending on how caught up they are with the symptoms, I usually ask folks like that, to say, if 10 different people come to me and they say, I have pain somewhere, and you ask them, what are the raw physical sensations? I'll get 10 different answers. One person, it's a pressure. The other, it's a throbbing. And the other, the air feels warmer than normal. The next guy, it feels cooler than normal. And the next one, it's a sharp knife. So I just kind of want to know, what are the raw physical sensations? And exactly right. People will have sometimes not terribly horrible sensations, but they're thinking about it, worrying about it. Why can't these doctors find out what's going on? And all those ways of thinking, sometimes we'll call it catastrophizing, causes more stress and more anxiety, which triggers a fight or flight reaction, which actually makes the pain worse. So you're right. That's a great place to intervene and actually do that a lot too.
That's awesome. Next one here. My right testicle feels pulled up in the wrong place, but there's no torsion. What could be going on here?
Yeah, so I see that a lot. That's of course, the testicles sit in the sac. They're connected to the body by the spermatic cord. So at the size of your little finger, and all the blood, all the nerves, all the lymph, the vas that carries the sperm runs up in that cord. And that cord has invested with muscle fibers, the cremasteric muscle that goes from the lower abdominal wall. And so normally, like if there's temperature changes, those testicles will pull up a little higher to stay warmer, or the muscle will release to cool off. So there's some normalcy to that. But yeah, we do see folks that for whatever reason, there's a lot of spasticity of that muscle, and the testicle can pull up inside. I'd say the majority of folks, once I just explain that's what it is, and we do our exam and find out that there's nothing serious, that's all that's needed. In rare cases, I've injected Botox, which is a muscle relaxant, into that muscle to help it relax. In rare cases, I've done a little surgery to strip off those cremasteric muscles. There is a small subset of folks when that testicle pulls up all the way past the scrotum into the lower groin, like into the subcutaneous tissue, and even up to the external inguinal ring. And that really does hurt, or it gets in the way, it's hitting during sexual activity or something, that we really do need to do something done. But
That small subset of folks, is it a similar pathology, you would say, or what do you think is leading to that?
I don't know. To be honest, it's a small enough subset of folks where it's happening that aren't just reassured, just knowing that it's a lot of times a variation of normal. I haven't really found that in that one case that doing a lot of mind body stuff has really been that effective. That one little niche, yeah. And I'll
Yeah,
probably just do something more anatomic, but not commonly.
I got you. Okay. My penis has an hourglass shape when
Mm.
flaccid. Why is this?
Well, the first thing you think about with that is Peyronie's disease, where there's some scar tissue in the corpora, and that we will see some. I mean, you normally more typically see that with, when they're erect, but yeah, you can feel scar tissue whether they're erect or flaccid, and that sometimes will cause an hourglass shape. Probably more often than not, it affects mainly one corpora, so there can be a little bit of bending to one side with the erect penis.
Do you have any recommendations on what someone could do if this is happening?
I mean, there's Peyronie's, there's a whole lot of schools of thought. And, it's interesting. There's very, very few things that will actually stop the process. So what happens with Peyronie's disease is this. Sometimes there's a known trauma. The most common one we see is people are having intercourse, the woman's on top, the penis comes out of the vagina, the woman comes out, it hits wrong, and there's actually a bending of the penis, and sometimes they pop. The corporal lining will actually pop, and there's a specific trauma. Most of the time, there's not really a specific trauma like that. It's more just little micro traumas to the lining of the corpora. But Peyronie's disease means the area where there's these micro traumas starts building up scar tissue and tearing it down, building it up and tearing it down. And that's a process that lasts about 12 to 18 months. There's been 400 or 4,000 things that have been tried over the years to stop the process. Hasn't really been a lot that can alter it. I mean, they tried injecting different things into the plaque. There is something called Xiaflex these days, which is a collagenase inhibitor that'll break down scar tissue. And in some cases, if you inject that into the plaque, it can help it get better. In most cases, we recommend waiting 12 to 18 months for this disease process to run its course. So we know where things stand after that. I'd say a lot of guys may have some bending of the penis. And in general terms, I say if it's straight enough where you can penetrate or have sexual activity, you don't necessarily need to have anything. Like, so there's Xiaflex injections for people that have severe degrees of bending, or particularly that's associated with erectile dysfunction. There's other surgeries, sometimes even a penile implant or prosthesis that's needed.
Yeah, and I have a lot of people that mention this, and I see it on Reddit and different places on the internet. And my perspective on it, if it's not Peyronie's and not from a specific incident, I think that it might be similar to hard flaccid. Something like that is taking place,
Yeah.
especially since it's happening in the flaccid state and not in the erectile state. So I don't know if you think that that's a possibility as well, especially if it's changing and it's not always the same.
Yeah, for sure if it's changing, because yeah, Peyronie's, I mean, those plaques are palpable on examination and they're pretty hard. So yeah, I mean, I don't disagree. It could be something like a hard flaccid variant.
Yeah. The next question is, I struggle with urine retention. It feels like my urethra is blocked. Is there any way I can overcome this issue?
Again, this depends on the person's age. Just in general terms, you want to make sure they're actually emptying. Okay, we have bladder ultrasounds that show that. Younger folks, if you think there's restriction, it could be some scar tissue in the urethra that could happen as a result of either trauma, like to the perineum, or sometimes months or years after sexually transmitted disease, particularly gonorrhea. Older guys, of course, can have enlarged prostates, and there could be some obstruction. So I think you need to rule out anatomic things for that first. If we think it's an obstructing prostate, there's medications that'll help kind of open it up. If it feels like there's restriction and we don't find any of those things, I mean, sometimes you need to make sure the bladder is squeezing and contracting well, because sometimes it's not. Sometimes it's due to a pelvic floor issue. Yeah.
Really helpful.
For something like that, though, there'd be plenty for me to rule out first in the office before. Yeah.
Yeah, thank you. Yeah, we're on a roll here. We have some more questions if you're feeling good.
Oh, man, I'm feeling it.
And let's do it. One of my symptoms is intense burning after urination, but only if I haven't ejaculated for about 2 weeks. By the way, I've had my prostate checked multiple times and it's all normal.
Mhm. Yeah. Burning after urination, I frequently find that that's a pelvic floor thing. The pelvic floor muscle relaxes, it opens up to allow the urine to come out. Then for whatever reason, it spasms with extra vigor, and that can kind of cause this post-void burning or something like that. Yeah.
Yeah, because they are saying that it's only happening if they haven't ejaculated for a while. So I assume
Yeah.
if they're ejaculating more frequently for some reason, they're not having the burning. Is there a way to even find out what's taking place, anatomically, or is it just kind of making suppositions?
It's probably just making suppositions. Again, the prostate obviously is a bag of secretions. And as I guess most of your audience knows, when a man ejaculates, only 5% of what comes out is sperm from the testicles. So 95% is fluid made by the prostate and seminal vesicles. And, that fluid basically carries, feeds, bathes the sperm as you're trying to get someone pregnant is really what it's for. So some guys, in all fairness, will build up a lot of secretions in the prostate. And if they're not released, sometimes can contribute to a lot of these problems. So in the old days, we tell guys if they have chronic prostatitis, like, trying to ejaculate a couple times a week to clean the pipes. And that's not really as common knowledge, but some guys just really do have quite a bit of buildup. We also see these guys that engage in these practices where they're being sexually stimulated, either solo or with a partner, and they don't want to release. That was kind of popularized by the book, The Multi-Orgasmic Male. And
Yeah.
I've known a number of patients over the years, and even some guys who teach the technique, that have really gotten into problems with their prostate from doing that. And it just builds up too much fluid and the body's not able to absorb enough of it. And it kind of can cause some problems like that. So
That's become very popular, and I think it can lead to a lot of these issues as well. And
yeah,
so I think the underlying emotional state and the reason why you're doing it often, because in many cases it's to get better at a longer ejaculatory reflex period.
right.
Someone's afraid that they're not going to impress their partner, blah blah blah.
Yeah,
So
yeah,
a lot of
exactly right.
pressure on the system. Yeah.
Yeah, exactly right.
Yeah. This one is, I am 99% better on most days, but my pelvic floor dysfunction still flares up from time to time.
Wait,
Like
what function?
their pelvic floor, it says pelvic floor dysfunction flares up from time to time. Like 1 or 2 days ago, I felt extreme pain in the tip of the penis in the middle of the night during a nocturnal erection. Could this be due to intense HIIT workouts that I've been doing or something more stress related in the subconscious mind? I think the question is like, for the most part, they're feeling really great, but they're having unexpected flare ups pop up out of nowhere. What are your thoughts on things like that?
Yeah. My thoughts are that for healing chronic pain, it is always, always, always 2 steps forward, 1 step back. And just realizing that you're going to have these little temporary setbacks and expect it and not freak out about it is probably the best I would have to offer.
Yeah.
I know you mentioned that in your book too. I love that about your book, that yeah, these guys are going to start getting better. Then they have a setback. And again, a lot of people, and I can relate to it, will freak out and damn, this thing that I was doing is not working. And just, yeah, they start thinking about it in a way that makes them stressed and anxious. And then, yeah.
Yeah.
So yeah,
Exactly. Take it easy, chill out, just keep moving forward, keep living life. If it's really bad or sticking around, I wouldn't necessarily use the magnifying glass just looking at the HIIT workouts or the food. You
right.
could consider those things, but also again in the book I talk about look in the mirror like you did. You're like, what was that thought that came into my mind
Yeah.
right before the back started spasming?
Mm-hmm.
Like, what was I thinking about before I went to sleep? Or was there some sort of trigger that I'm not really being honest about?
Yeah.
That can be useful. Not that you have to really stew on that, but also that can be, I think, one of the most useful parts of the flare up situation.
Yeah. Yeah, for sure.
Awesome. How would you say that mind body syndrome is similar to, or is it different from general anxiety? Like mind body syndrome, these things we talk about, TMS, neuroplastic symptoms, is it similar? Is it different from general anxiety? And what are your thoughts on anxiety medication to treat the mind body symptoms? So it's a question about, yeah, anxiety and how it plays into all this, I would think.
Yeah. So first off, I'm not a big fan of chronic anti-anxiety meds, particularly the benzodiazepines. I have seen a lot of people that has not been good for them long term. I mean, it can be hard to get off. So to the extent that we can not start folks on anti-anxiety meds, the better. There's a very good book called the DARE, which is, I forget the acronym, but the DARE book for anxiety. If you look it up on Amazon, there's thousands of reviews. It has like 4.8 stars. It's a very good cognitive approach to dealing with anxiety. As far as, it's interesting. At the end of the day with Sarno, a big part of what I think why he's made inroads is people have pain and they don't worry about it as much. They say, oh, I'm having pain, my muscles are locking up, but it's not caused by anything serious. It's due to something I'm not consciously aware of. But there's just a huge cognitive part to the Sarno piece because people are not freaking out about it, So that just goes back to changing how we think about our symptoms and learning to think about them in a way that's more empowering and more calming and stuff like that. But yeah, as a general rule, a lot of times folks first of all, folks that have chronic pain, again, a lot of times they catastrophize. So part of anxiety is thinking about our uncomfortable sensations such a way that we actually get more stressed. So a lot of times anxious people have chronic pain more often than someone who doesn't freak out as much when confronted with, uncomfortable sensations like that. And the other thing, just in general, to me, someone says they're anxious, they have anxiety. In my mind, what I think is happening is that the brain is reading a body whose physiology is stuck in a stress physiology. And then we may have certain thoughts about that, but when someone's body is stuck in a fight, flight, freeze physiology, the brain can interpret that as anxiety. So it just goes back to the same thing. Someone with anxiety and the mind-body syndrome, it's all the same thing. They're stuck in a physiology that is exacerbating the symptoms. It's making the ground fertile to have stuff that doesn't get better that well. And it's all the same treatment. We got to shift people out of that chronic stress physiology.
You just got very quotable there. Anxiety. The brain is reading a body that is stuck in stress physiology.
Yeah.
Really?
Remember we were talking about earlier, like the soda can example that you liked. There's stressors. There's a lot of survival energy trapped in the body as chronic myofascial tension. So I think we're walking around with a lot of that and our brain is checking in on the body regularly. Then it's saying like, oh my God, the body's tense. There must be something to be tense about or stressed about. So I think a body that's locked up, the brain again reads that I'm not safe. There's something going on. And that's one of the reasons why I think TRE is so effective, that as you release these chronic tensions from the body and unwind those tension and bracing patterns, the brain literally says, man, I feel like I must be safe. I'm safer, you know? It doesn't keep you stuck in this limbic system loop as much.
That's amazing. We have three more questions today.
Right.
Um, I'm dealing with constant urge to urinate, hesitation, slow, weak flow, and penile pubic area bladder pain. All of my urine, blood tests are normal, PSA and prostate normal, uroflow is normal, normal MRI. How necessary would a cystoscopy be in this situation?
I think if the urine tests are normal and everything else is normal, that would be pretty low yield. Yeah. Sometimes if I do a cystoscopy and something like that, what I find is that as I'm going down the penis, going through the external sphincter, the pelvic floor, some of those guys are really, really locked up. So sometimes it gives me an opportunity just to get a sense of how tight the pelvic floor musculature is, but probably not going to have a high yield as far as finding some pathology or, well, I mean, a bladder tumor or something like that. So probably low yield. I see 5 guys like that a week, and I will usually start them on some medication to calm down those hypersensitized nerves, and maybe work with pelvic floor physical therapy, and then do just kind of your approach, which I really feel should be the overarching thing they do. There was this, I think it was a book written by Bernie Siegel, who was this famous surgeon from Yale. And he was one of the pioneers of understanding mind body healing. And he wrote a book called What to Do Between Office Visits. So I would say that for my chronic pelvic pain folks, do all this other stuff, medication or physical therapy or TRE. And then what they should be doing between office visits is reading The Root Truth. I mean, seriously, and doing those exercises and taking them seriously.
Yeah, amazing. I have lower sacrum tailbone area pain. How common is it that you see pain in this area with CPPS or pelvic floor patients?
So I don't know. I mean, I've not seen a huge correlation. But when people have pelvic pain or inflamed prostates, I would say it's like if you drop a pebble in a pond of still water and the ripples go out in all directions. Like in general, when folks are having pain, it's chronic, then sometimes the surrounding nerves start getting more sensitized. And then the pain that started like in the prostate area extends out. Now they're feeling it in their penis, and then it extends out a little more over time, and they're feeling it in their testicles, and then it extends out over time, and they're feeling it on their thighs and their lower back. So sometimes the nature of neuropathic pain is that it can extend out like that. You could also feel chronic muscular tension in those areas, obviously, as well.
Just to add on to the question, then I see really commonly digestive dysfunction coupled with pelvic floor issues. It's the most common coupling I see. And what are your thoughts on that? Like, what is creating, I mean, people that are trying diets and cleanses and everything, and it's not necessarily changing it that much.
Yeah. So, irritable bowel syndrome, again, it's a classic thing where I'm sure you can throw out that curve, the Porges polyvagal model curve, but yeah, that's just classically folks that are vacillating between a high sympathetic fight or flight state and a dorsal vagal, again, the bad parasympathetic. So the effect of the sympathetic nervous system innervation of the gut is it slows it down. So there's bloating and constipation. The gut motility is slowed down. When they go into the parasympathetic, then there's more hypermotility, cramping, spasming, diarrhea, and it literally will go back and forth. So again, that's just it's all part of the same spectrum. When the physiology is off, it manifests that way in the intestinal tract. It manifests as the ways we've been describing in the urinary tract. Yeah.
Nice.
Yeah. That's the beautiful thing of this. I'm always just saying every day I'm thankful for the Porges polyvagal model, because it allows us to show the effects of the physiology and the downstream effects, and then understanding that what causes physiologies to begin with is frequently early stressors and traumas, and it just ties it all together so beautifully.
It's all there. The science is there. We're not making this stuff up.
Yeah, right.
So last question here. I have urinary frequency, urgency, as well as erections that are unstable and thinner at the base. My penis has minor torsion and presents tighter on the left side. Is this a muscle and ligament issue, or what could be done here?
I mean, I think a certain number of guys, just the penile torsion by itself, I mean, a certain number of guys, just the penis is torqued. If you do enough circumcisions like I do, I mean, I don't know, 5-10% of guys, the penis, just when you remove the foreskin and it's much more visible. You see the thing torque. So the torsion in and of itself, I'm not really worried about. That's common. A little bit less flaccid, again, assuming that you've rolled in all the stuff, roulette Peyronie's, that's probably just not enough blood flowing in, or the blood's flowing in and the veins are leaking it out. And I think as much as anything, that could be a reflection of underlying stress state, particularly if someone who's otherwise young and healthy. And then what was the first part of they were having urinary frequency?
Urinary frequency and urgency. And yeah, erections that are unstable is what they said. So
Yeah, kind of the same thing we've been talking about. Rule out the bad stuff, rule
yeah.
out prostatitis. Yeah.
Yeah. You make it so simple. Everyone wants specific, like hyper personalized, complex answers, though.
Yeah. It's just when you jump up to that higher logical level, everything's kind of just an offshoot of that.
Yeah,
Yeah. Yeah. And like, I think you were saying at the beginning, I mean, modern medicine's great at looking at this disease process, but oh, that must be unrelated to this disease process. And that is it so seemingly unrelated. And they're really not, that's right. What holistic means, you look at the whole person and what is an underlying unifying principle. And now we understand these physiologic principles, and it really does explain a lot.
for sure.
And I still don't think 1 in 100 doctors, even like some of the stuff that we've been talking about today, that is like common knowledge to you and me, like to even say somebody's body and physiology gets stuck in a chronic stress state that's running on autopilot. I even think to this day, not 1 in 100 doctors really thinks that. Like most guys in med school, they'll teach you like, again, you're in the woods and the bear jumps out and you either fight or you flee, but assuming you get away, your physiology is supposed to normalize. And we know for a lot of folks that doesn't happen. To me, the whole gist of the ACE study, the adverse childhood experiences study, shows, why do these people with more adverse childhood experiences get sick and have early death and chronic pain and heart and lung and GI disease and addictions and cancers years or decades later? And it's because that programs how our physiology is going to run for the rest of our lives. And again, your physiology is running that way. Like in the case with me, I mean, with 35 years of chronic fatigue, I was cycling between a high, dorsal freeze and a high, sympathetic. I didn't really know it. All I knew was like who I am and how I feel in the morning. I knew I felt like crap a lot of times, and I was exhausted a lot and had brain fog. And I could look at other people also going through med school or residency and say, God, they seem a lot more functional. But all you really know is how you feel. So
Yeah,
sometimes these
exactly.
disease processes, when you get them, it really is, it's a wake up call. It's the engine light on your car. And again, that's what I loved about your book. It just, these diseases, to be honest, are really an opportunity to heal so much of our lives, and almost always for the better.
Mm. Life is so much grander, more beautiful. You feel more like you once you've dropped the parts of you that were making you sick. But they were doing that on purpose, like to help you actually breathe and be and flow and be alive, because
Yeah.
you're so constricted because of the way the nervous system was molded. And it's okay. We are victims of circumstance and environment until we have conscious awareness to then be able to assimilate and just in a sense transcend or release.
Yeah.
You have to dis in
And
order to transcend.
yeah. And like you said, I mean, we did what we needed to survive early childhood stuff. And so I don't want any grudges towards the parts that were stuck. I mean, they really were doing the best they could at the time. And I kind of want to love and accept those parts. But once you're an adult, you got to be able to maybe transcend them. And yeah, having physical pain, for better or for worse, is a great motivator, isn't it? For a lot of the patients.
It moves you. It moves you.
Yeah.
Last thing, this has been extremely helpful. And I know that everyone's going to want you to come on like every week now for free medical advice, but we appreciate this and we look forward to collaborating at some point and on other things. But also, one thing, like one person, they're struggling, they're suffering really dark today. What's just one thing you want to tell them right now?
Yeah. What I want to say is there's a tremendous amount of hope. You can actually cure this, not just treat it, not just control it, not just medicate it, but a lot of times this stuff is very, very curable. It is a little bit of a paradigm shift in thinking, but the stuff that we're doing is all based really on medicine and physiology and understanding the nervous system and neural pathways and the interplay to all those things. It's possible to get cured of this. I cured my back pain. I see a lot of patients get cured. It probably takes a multimodal approach of things in addition, maybe to what your doctor's recommending. Yeah, that's what I'd say. There's a lot of hope.
A lot of hope. Yeah. Thank you so much, Dr. Robbins. This has been amazing.
My pleasure. Thanks for having me on.